Hello and welcome to the very first Bridge Talk Show. My name's Vivienne Parry. I'm a science writer and broadcaster, and every year for the last decade I've hosted the TV show at the annual EASD Congress. Now, during those 10 years, it's mostly been talk about type 2, the new GLP-1s, and very little about type 1, until that is in the last couple of years. And the interest and enthusiasm and excitement about type 1 diabetes has become overwhelming. People are talking about early diagnosis, they're talking about prevention, and some people are even talking about cure for the future. So it's at this absolutely exceptional moment in the evolution of type 1 diabetes and its treatment that we're bringing you the Bridge Talk Show. So we've got two experts with us today who are going to set us up all on the same page about the pathophysiology and the science behind type 1 diabetes. So can I welcome, please, Jacques Beltrand from the Institut Cochin in Paris, and also Luis Castaño. And Luis is a pediatric endocrinologist, also from Cruces University Hospital and professor at the University of País Basque in Bilbao. Welcome to both of you. And
Thank you.
Just to say, right at the very top, it's actually remarkable that it was only in the 1970s that type 1 diabetes was discovered to be an autoimmune disease.
Yeah, in 1974, something happened. They were discovered the autoantibodies to islet cell autoantibodies. And that was the first idea that probably type 1 diabetes, that until that moment we only knew that they lack insulin, that probably will be an autoimmune disease. That was the beginning of the autoimmune era for type 1 diabetes.
So tell me, Luis, what's going on in type 1 diabetes?
Okay, type 1 diabetes is a disease that is autoimmune disease. That means the immune system wrongly destroy beta cell, insulin producing beta cell. Then that brings a absolutely lack of insulin, and glucose is growing and lead clinical diabetes. This is an autoimmune disease, autoimmune destruction, and lack beta cell, hyperglycemia.
So I guess at that moment, we stopped thinking that we could cure it by telling people to alter their lifestyles, as we do for type 2, and really concentrated on thinking of it as an autoimmune condition. What about the autoantibodies? What does the discovery of the autoantibodies mean?
So the discovery of the autoantibodies clearly changed everything in diabetes. For years, and even still now for the general audience, diabetes, it's a metabolic disease. It's all about glycemia and everything that goes with food and lifestyle. But type 1 diabetes is a disease of the insulin secretion, and it is linked to the destruction of the cells that are producing these crucial hormones. And the discovery, years after years, of the different autoantibodies linked to this disease are really shown that this is an autoimmune disease. And like many autoimmune disease, it starts years before the appearance of the symptoms. That means that we can probably do something before the needs for insulin.
And is it just one type of antibody, or are there a range?
There are four types of autoantibodies: the GAD-A, the anti-insulin antibodies, the A2 antibodies, and the ZD8 autoantibodies. These are the four ones that have been clearly identified, and these ones are used because in all prospective cohorts, these are the ones that have been studied, and we know, based on the number and the titration of these antibodies, we can define the risk of the occurrence of insulin dependency.
Now, the one thing that has always been relatively clear is that there's a genetic component to type 1 diabetes. What do we know about the genetics of type 1, Luis?
Type 1 diabetes is a combination of two factors, genetics and environmental factors. The combination of both, genetic susceptibility plus the intervention of some environmental factor, activate the immune system.
So you can have the genetic factor, but if you don't encounter the right trigger, you'll never have the type 1.
Exactly, because, for example, monozygotic twins, that they have the same genetics. Only 50% of the monozygotic twins, the second brother, the second twin, has diabetes. That means you need, in addition to genetic susceptibility, another factor that is environmental. And they need both to produce the disease.
So if you are a child and there's another sibling in your family with type 1, does that mean that you will get type 1?
Sure, it's not sure, that means. But we know after different programs and studies that has been performed in Germany, in United States, in Finland, in first-degree relatives, we know that a first-degree relative, a brother or sister, the parents or the doctor or the son, they have 10 times more the risk to develop diabetes than general population. Then, of course, they have at risk because they have some genetics in common.
So when we think of genetics, we think of an autoimmune, we think of the HLA region. So that's the bit of the genome that, if you like, codes for the immune system. But that's not where all these genes are located, is it?
Yeah, initially we were thinking about that all the power of genetics was HLA. At this moment, HLA represents more or less 50% of the genetic susceptibility, 50%. The other 50% is, there are more than 60 genes that the combination of different variants of these genes, polymorphic genes, the variants, give you the susceptibility. The question is that about all of these 60 genes, HLA only has 50% of this risk. Then we use HLA. Until now, we were using HLA as marker for to detect genetic susceptibility. But today, there are, with the new molecular biology methods, we can analyze not only HLA, but also the other genes, and establish a score of genetic risk, polygenic risk score for type 1 diabetes.
So it's a fascinating condition, absolutely fascinating, very complicated in many different ways. But what we absolutely do know, an autoimmune condition, quite different from type 2 diabetes. Fantastic. So there you have it. These autoantibodies are the fingerprints of type 1 diabetes, but not always, and it's complicated. Now, we've just been talking about how these fingerprints, as it were, of type 1 diabetes appear, these autoantibodies, and it opens the way to early detection methods. But Luis, how early do we see these autoantibodies appearing?
We have data from different studies in first-degree relatives. We have DAISY from United States.
It's a big study, DAISY.
Big study. Also, Baby Diab, that they follow newborns from parents with type 1 diabetes, that means first-degree relatives. They follow up and they realize that a group of these babies develop autoantibodies. And after that, they need insulin. They get clinical type 1 diabetes. Then that allows us to talk about early phases of type 1 diabetes. Before, we were thinking that clinical diabetes was the real onset of the disease. Today, we know that before the clinical onset, before clinical symptoms appear, there are the things that we call early phases where you have the disease and you can detect the disease, but without symptoms. At that moment, the autoimmune reaction is already going. The insulin producing cells are being destroyed, and you, at that moment, you only have autoantibodies. You have normal glycemia, but you go gradually going to clinical diabetes. Then we know that there are some early phases where we can know and maybe intervene.
Because what's interesting, Jacques, is people imagine, and lots of people think this, that diabetes, the day you get the symptoms, that's it, your pancreas has packed up. But actually, it's a much more gradual process over perhaps many years. Is that the case?
Yeah, it's the case. We could do a parallel with kidney disease. In kidney disease, you have an injury of the kidney that leads to chronic renal failure, and the patient are follow up from the beginning till the moment they need a graft or they need dialysis. And it's really the same way we should see diabetes now. Diabetes, it's an injury against cells that produce insulin, and the disease starts as soon as the first beta cell dies from the autoimmune attack.
But when the first beta cell dies, you've still got quite a lot more that are undamaged.
Yes.
And that's a key point, isn't it?
Yeah, that's a key point. And yes, during many years, the remaining beta cells can compensate for the loss of the insulin secretion. But still, it is diabetes. As soon as the patient has more than 2 autoantibodies, we can say that there is an ongoing autoimmune process and there is diabetes. So in our clinical practice now, finding 2 or more antibodies in the blood of the patient means that we have to say to the patient, you have diabetes, and at some point you will need insulin. And it's something that has really changed in the last years in the way we take care of the patients.
So you talk about 2 antibodies there, and that's also highly significant because if there's only 1, am I right in thinking that actually some children go back to being negative again?
Yeah, this is, we think that maybe having 1 antibody, you already has a risk, but it's lower. And we know that sometimes when you have 1 antibody, in the follow-up, this antibody can disappear. Then we don't think that we need to put a lot of energy in that period. And the only thing that we need to do is to follow this child to check if other autoantibodies are appearing. Because sometimes becoming negative and disappear, then the risk is much lower. And
how many of those people with 2 antibodies will go on to develop diabetes?
We have data from I think that is from the FRIDA study. It was in first degree in general population. And we know that if you have 2 antibodies, the moment that we call stage 1 of early phases, stage 1, if you have 2 antibodies, you have almost 50% the risk to develop clinical diabetes in 5 years follow-up. If you have 2 antibodies plus some dysglycemia, that means stage 2, the risk to develop a clinical diabetes in 5 years is almost 80%. That means you are practically close to clinical diabetes, stage 3. Before we were talking only about type 1 diabetes. Today we are talking about preclinical or presymptomatic stages, stage 1, 2 antibodies, or stage 2, 2 antibodies plus dysglycemia, and stage 3 is the clinical onset of type 1 diabetes.
So Jacques, how has this knowledge of autoantibodies helped in understanding staging in diabetes?
So first, I really want to highlight that all the patients with 2 or more antibodies will develop clinical diabetes during their entire lifespan. That's important for the patients because it means that when you have 2 or more antibodies, you have type 1 diabetes. These autoantibodies and all the type 1 diabetes has now been divided into 2 phases, preclinical phases and clinical phases. And the 2 preclinical phases are called stage 1 and stage 2. Stage 1 means at least 2 autoantibodies, but no dysglycemia. That means that the patients still have a production of insulin that allows you to maintain normal glycemia. And the second stage, it's a stage where the patient have 2 or more antibodies and some level of dysglycemia that can be detected using very specific tests like the OGTT or using glycemic alter. And then stage 3 and stage 4, that are the clinical stages.
But what happens when you have stage 3 type 1 and then your antibodies disappear? Because this is, I find, extraordinary, that these antibodies kind of come, and then when you think that they ought to be there kind of in huge numbers, they then disappear.
So this is still an ongoing story, and we are still learning from the follow-up of the patient. We are still learning on these different stages. We know that some patients can lose the autoantibodies just before entering the phase 3. Some patients can have at stage 2 antibodies, but only 1 when they enter stage 3. It's probably because when there's no more beta cell to destroy, there's no more antibodies. That's difficult to manage for us as physicians and also probably for the patients, but at the end, all the patients will develop stage 3.
So it's a complicated story. It's not an easy story. And my sense from you both, actually, that this is an evolving story.
Yeah, it's an evolving story. It's still a challenging story because the diagnosis of stage 2 is not so easy to do. Sometimes you need to repeat the test to be sure that the patient is in stage 2. And it's important for us to learn more about this stage 2 because we know that it is the stage where we can probably delay the appearance of the need for insulin. So we are still in a process of learning these different stages.
We've heard about these autoantibodies, and there's the really tantalizing prospect of population screening ahead of us. Luis, what studies have been done already that support population screening?
You know, after the first degree relatives studies, where we demonstrate that type 1 diabetes start before, we were thinking that probably we need to check what's happening in general population, pediatric general population. And there are several studies, mainly one in Germany, the FRIDA study, but also in the United States, in Barbara Davis Center, that they were analyzing the evolution of general population, pediatric general population, and how they act and how they were at the early phases of type 1 diabetes. And they were very interesting because they were able to demonstrate the benefits of general population screening. They show that, in general, in our population, 30 to 40% of new onset children, they start with type 1 diabetes with ketoacidosis. Doing general population screening, you can decrease 10 times the onset with ketoacidosis. This is important. In our experience, we have been performing this kind of analysis, and in my center, that is a reference center in Spain, we have around 35% of the children without screening that they onset type 1 diabetes, clinically onset, with ketoacidosis. After doing the screening, we have been able to decrease to 3%. 30% to 3%. This is very important.
And that's a horribly scary thing to KA.
And one other question is, for example, usually in my center, children, they are hospitalized at clinical onset, an average of 8.5 days to be teach, to be recover, etc. We were able to, if you are doing the screening, you have time previously to educate the people, and we were working without any hospitalization. This is again a very important benefit. Then I think that is very important to think that the data that we have in first-degree relatives, we can apply also to general population, and probably it's very important to do general population study. We need to take in mind also that doing first-degree relatives screening is around 10% of the people that will become diabetic. Once you take all the group of type 1 new onset, 90% they don't have first-degree relatives. They came from general population. Then if we want to be effective with these benefits, we will need to move from first-degree to general population.
And that moves us on to general population screening. Where are we with that? Or where could we be with that, Jacques?
So what we are learned from, for example, from the FRIDA study, we are learned what is the best way to do the screening in the general population. So the best screening in the general population should be started early in life, probably around the age of 2. And so the first screening must occur between 2 and 4 years of age, and it must be repeated till the age of 12 every 4 years, basically. So this is the best way to catch most of the patients with type 1 diabetes. But of course, we need to take into account the specificity of each country, and we also need to take into account the cost effectiveness of the screening in the general population. We have already know that the prevention of ketoacidosis is crucial. It's crucial for the families. It's crucial for the children. And it's also crucial for the natural history of type 1 diabetes, because we know that children that start diabetes with ketoacidosis have a less well-controlled disease later in life. So this entry is really an important point. But on the other hand, we need to do a screening that is effectiveness and that is based on the epidemiology of the countries and also on the healthcare system of the country. For example, our Italian colleagues have decided to do a one-shot screening. So basically, based on the general pediatrician, they screen every children between the age of 2 and the age of 6, and we can say now that it is a success. This politic, and they decreased by 30% the number of ketoacidosis, even in children that have not accepted to be screened, because when you
what do you mean by that?
Because when you screen, you speak of diabetes with the family, and even if the family doesn't want to be screened, they are aware of the signs of type 1 diabetes. So you change the mind of the whole population, the mindset of the whole population. So you see, by screening the type 1 diabetes in the general population, you really change the natural history of the disease. And as you said, you can start the follow-up very early in the disease. So you can do a better follow-up. You can follow the family, help them to enter very smoothly in the disease, and in the future we'll be also able to delay the need for insulin.
So we're talking. Sorry.
Yeah, I want to add something that I think that is very important also. Because we have been talking about the benefits decreasing the complication at clinical onset, but we need to remark that in the last 30 years, in addition to analyze the evolution of this type 1 pre-diabetic people, we were trying to use different strategies to try to modulate the immune system. using different drugs and trying to really go to the problem. The problem is the immune system. And I am convinced that probably in the future, we will be able to cure. Because if we can delay and delay and delay, I think that this is great.
Yeah, and it's very significant, isn't it, that the Juvenile Diabetes Research Foundation, which is one of the big funders in diabetes research, they've just renamed themselves Breakthrough T1D because they feel that now is the moment.
Yeah, now is the new era. Yes. I think that this is great.
Yeah. So I'm taking from you that this is something that's really worthwhile doing, that we haven't quite got the screening protocols in place yet, at least for the general population. Although, Jacques, I was just going to say, presumably there's a bit of opportunistic screening that you could do. I mean, for instance, women with gestational diabetes.
Yeah, till now we only spoke about diabetes in children, but around 50% of new cases of type 1 diabetes occurs in adults, and we need to keep that in mind. So there are situations in adulthood where patient needs to be screened, and the pregnancy is one of these situations. A mother with gestational diabetes must be screened, and if there are more than 3 autoantibodies, it means that there are 80% of risk that this woman will develop type 1 diabetes in the coming 5 years. So we don't need to forget those patients that also needs to be screened.
Yeah, and some years ago, they started to do general population study, mainly in Europe, in Germany, Annette Ziegler, the FRIDA study. But at this moment, there are different programs that they are already starting in different countries. We have the ELSA study in UK, the Union in the north of Europe. In Spain, we have a general population study. In Italy, there is a law that recommend a general population. That means things are moving, and I think that this is the way to achieve the goal that we are looking for, that is the cure of type 1 diabetes.
So really exciting times. Just leave us, because we must finish this segment now, but just leave us with just one thought about the future that you'd like people to take away with them.
I think that we are entering really a new era of type 1 diabetes treatment, and it will all start with screening. If we know it's time to screen, each country must decide how they want to screen their children, but they need to start to screen. And by screening children, we will learn more from the natural history of the disease. And I know it's the scientific that is speaking, but we still need to learn more about this autoimmune process to be able to change the life of our patients. And so we need to start screening.
Yeah, and I say very short sentence. We need to move on in this direction. I think that this is the way, and we never have been so close to the idea to avoid type 1 diabetes. Move on.
Jacques Beltrand, Luis Castaño, thank you so much for being with us today. So what have we learned? First, that type 1 diabetes is quite distinct from type 2 diabetes. Type 1 is an autoimmune condition. We've learned that autoantibodies are present months or years ahead of clinical symptoms of type 1, and that the presence of these autoantibodies can be used in general population screening in order to reduce the incidence of diabetic ketoacidosis, but it also opens up a window to potentially delay the onset of type 1 diabetes in the future. It's a very exciting time in type 1 at the moment. Thank you so much for listening, and there'll be another episode of the Bridge Talk Show very soon.